I call second speaker Professor Ahmed Tarawah من المملكة العربية السعودية. He will speak about genetic prediction of sickle cell disease.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Thank you, Prof. Amal Bishlawi, for this gathering, and thank you all. And always, whenever I am in Egypt, I don't consider myself as a guest. I am in my country. As Prof. Tantawi yesterday, when she said about thalassemia, even in sickle cell anemia, they get married, and this is the last sickle cell anemia who get married last year, and they can reproduce. This guy here, he had been on hydroxyurea since the childhood, and he had a couple of attacks of priapism, so don't ignore that. Okay. So this is two patients actually. The one on your left side, she is 16. He is 16-year-old, and he had a stroke by the age of 3, and he was on the regular transfusion program. And 2 of his siblings, they had a stroke too. While the other guy on the right side of yours, he is 15 years, and he has mild sickle cell anemia course, and also his siblings. So there is difference, though they have same sickle cell disease, but one of them is severe, the other one is mild. Facing a problem. And since the stroke prevalence in Medina, or the western of Saudi Arabia, Medina, Jeddah, it is 10 to 13%, while the stroke rate in the eastern province of Saudi Arabia, it's almost 1%. So there is difference between the sickle cell anemia between the west and the east, although it is sickle cell anemia. 100 years ago, James Herix has described the sickle cell anemia, and clearly you know that the sickle cell anemia, it is a substitution of a single nucleotide lead to the valine in place of the glutamine, which has something to do with the charge, lead to the filaments of the sickle cell anemia and the sickle cell shape of the RBCs. And since long time, we know that sickle cell anemia, it is haplotype Senegal, Benin, Bantu, Cameroon, and Arab Indian. And since 70s, we know that the Arab Indian type, it's milder form, while the Senegal Benin type, it is the severe form. But now we know that it has nothing to do with that, rather than it is different sickle cell anemia with different type of complications. And this is probably the nucleotide in the place of the haplotypes we know. Again, earlier on, probably 40 years or so, when there is sickle cell plus alpha-thalassemia, we know that the rate of hemolysis is less in those patients. The same with the beta-thalassemia. They have less severe type of painful crisis. And we know also the hemoglobin F effect on sickle cell anemia, and we know that the sickle cell, the hemoglobin S, without the hemoglobin F, it leads to participation and sickle cell formation when there is deoxygenation. The things doesn't happen when there is hemoglobin in F enough, like 15, 20% or so. So it makes some sort of dilution, make the complication or painful crisis or vaso-occlusive crisis is less than the others. We can predict from that high hemoglobin F protect against severe sickle cell anemia, while still some of authors, they believe that it does not. I'm not sure what is happening with my slides. Okay. Okay, some authors, they believe that there is little or no correlation between hemoglobin F and sickle cell anemia. For example, in Saudi Arabia, the Saudi, they have high hemoglobin F, but still they have severe anemia. So still we face some patients with high hemoglobin F and severe type of anemia. The case is not the same in hydroxyurea too. These two patients of sickle cell anemia, the one on your left side, she has vaso-occlosive crisis, 2 to 3 per year acute chest syndrome, and has been started on hydroxyurea, where her hemoglobin F has increased from 9 to 45%, while the one on your right side has the same clinical story and has been started on hydroxyurea, but the hemoglobin F has not been increased too much, and the severity has not been changed that much. So there is difference between the two in their response to hydroxyurea. So when have been dig down into the issue of molecular genetic of those two patients, they have found that there is difference between the two molecular genetics of the two patients, and they have studied that into more digging down and why this happened for those patients. And they have found that the BCL11 single mutation or SNPs in this gene lead to that there is difference between the two groups. So this study by later, longer time, probably 10 years ago, they have gone back to the patient in the study, the CS sickle cell disease, and the Brazilian study, which is famous, and they have looked into those SNPs, and they could find that there is difference in those type of patients. So at that time, people, they start to believe that there is something related to the SNPs on those patients. In hemoglobin F, those patients whom they are responding or not, they have found there is 19 SNPs controlling the effect of hemoglobin F in sickle cell patients. Again, this is some of the SNPs has been found long time ago, probably 10 or 12 years ago, that those SNPs has effect on the hemoglobin F manifestation in sickle cell anemia. So probably by 2008 or so, there was something called genome-wide association studies. They are studying the molecular genetic in sickle cell anemia with different type of complication and the pathogenesis of sickle cell anemia. And we know now sickle cell anemia, it is not a sickling RBCs only. It has something to do with coagulopathy, endothelium, adhesions, whatsoever. So they have gone on those and they have studied the SNPs of those patients. So they have found that some certain gene has nothing to do with the hemoglobin gene. There is an areas where it is probably present in every one of us. But in sickle cell anemia, we could correlate those SNPs with certain complications. So this is the GWAS for sickle cell anemia, and it is easy to study it currently. So we know that in sickle cell anemia, that the problem, it is not only the RBCs. It has something to do with all of those things, endothelium adhesions, inflammatory process, the coagulopathies, and so. For the stroke, for example, this is the certain genetic modulation in some patients. So those patients, they may have only the large vessel stroke or the small vessel strokes based on the genetic type they have. وأنا مش عارف هي بتتحرك ببطء كده غريب شوية. In another study where they have studied sickle cell patient whom they have a stroke and another group without a stroke, and they look into VCAM gene where they have found it is more common among the patients whom they have developed stroke rather than the others. And again, they have widened that study, and it has shown that there is certain SNPs or genetic modulation does affect those patients with sickle cell anemia strokes. And again, the type of stroke, whether it has something to do with the large vessels or the small vessels based on the genetic modulation they have. هي بتطلع عندي قبل ما تطلع عندكم ف I'm sorry. يعني الكمبيوتر هنا سريع ويوصل لهنا اصلا مسافه كبيره من هنا لهناك يعني. Again, for the silent stroke, they have studied those patients with silent stroke whom they have discovered accidentally during the routine workup. So again, they have found some lost sight has been affected with certain genes. A vaso-occlusive crisis, one of the most common problems in sickle cell anemia, and again, they have studied those patients and they related to the MBL 2, where they have shown that some patients, they have certain SNPs, they have more vaso-occlusive crisis than the others, and we can see that in our daily life. And this, again, some SNPs has been associated with the higher rate of the vaso-occlusive crisis. Infection, another problem in sickle cell anemia, where again, some type of the SNPs has shown there is a good correlation with those patients whom they have recurrent infection in sickle cell anemia. Again, other SNPs has shown correlation with the gallstone. So some patients, they have gallstone, while the others, they don't, though all of them, they have hemolysis. But those patients with those certain SNPs, usually they will develop gallstone, and it runs in families. We do that in our life, that we found there is gallstone complication of sickle cell anemia in certain families, not the others. Again, this SNP found that increased the rate of the hemolysis in sickle cell anemia patients. Pulmonary hypertension, probably this is a problem for sickle cell anemia in adults. They have linked those two SNPs for the pulmonary hypertension in sickle cell anemia, and it can predict for the pulmonary hypertension. This is a big list. Again, it is small. You don't need to read it, actually. Those type of SNPs, it has been related that this patient may have pulmonary hypertension when he gets adolescent. So, with all of this work people has done, they came with a conclusion that all the complication of sickle cell anemia, or most of the complication, has a certain SNP indicate that this patient will develop. So, if we have UGT1, that we know that this child will have gallstone later on, so we know this information. Or we have VCAM1, so we know that this patient may develop a stroke. Just a reminder that late 90s, that when Adam has came with the theory of the transcranial Doppler and the relationship, and after that we know that high velocity in transcranial Doppler, it is a prediction for a stroke to happen. So we came with stop 1 and stop 2. So now we don't wait for the stroke to happen. Actually, based on the transcranial Doppler, we predict the stroke, and we start the program of transfusion or even stem cell transplants. Only depends on the transcranial Doppler. This is the GWAS for all complications in sickle cell anemia, and this is how you go over for that. So, in the coming future, if we can do it, which is coming probably in coming years, in the guideline in sickle cell anemia, we will find that now, if you recall the last guideline, that there is clear about the transcranial Doppler, while the guidelines before that, they just prefer it. Now, the coming guidelines, it will be something related to the SNPs and genetic association, so we will do it for routine for every sickle cell patient, and we will know this patient will have gallstone, that patient will have a stroke, and maybe we will start the transfusion based on the SNPs those patients have, and this made the newborn screening for sickle cell anemia in certain areas like in the Gulf, it is necessary to be made. And again, for those patients with therapeutic issues, that we know that this patient will never get benefit from hydroxyurea because of the SNP he has, and that is why we know that this patient may get benefit. And something much more when we study the molecular genetic of sickle cell anemia. So sickle cell anemia, it is not a big molecule issue, valine and glutamine. It is something much more than that, and we can get benefit out of that. By this, probably, I finish my presentation. Just I remind you, next year for Middle East, North Africa Hematology Congress will be again in Medina in April, like this time probably. And the third Middle East, North Africa, it will be again in April 2001 in Dubai. And I hope we will see it the year after here in Egypt, inshallah. And thank you.
Thank you, Professor.